This is Health UnaBASHed, broadcasting live on Healthcare Now Radio. Health UnaBASHed is a conversational platform where healthcare meets innovation. We engage top industry talent and dive into the heart of health and wellness, from vision to business model, to bring you the latest developments in health tech, to promising AI applications, policy, and ultimately impact on the public's health and well-being. I'm Gregg Masters, co-host, executive producer, and I'm joined by the digital health aficionado himself, author, editor, global thought leader, and in his executive capacity, steward servant, Gil Bashe. The mic is yours.
Gregg, as always, I want to thank you for that lovely introduction. And it's such a pleasure working with you. You've had a lot going on the last year, and I hope to hear a bit more about that. Today we have a very, very special guest, someone we know, certainly our listeners know extremely well. It is someone who has been involved with the program Health UnaBASHed since its inception, and is really the guiding light of making the program possible. It's not me, by the way. I'm privileged to be the host, but there is, shall I say, there is a magician or a wizard behind the curtain who often is comfortable staying behind that curtain and not necessarily being front and center. And that Wizard of Oz, Gregg, is you. You're our guest today. And it's really a pleasure to have you. I just want to let our listeners know you've been through a tremendous amount in a very short period of time. Things have touched your life, and those of us who are close to you, as a result, vicariously, it's touched our lives. And that, of course, is the death of your son from a tragic cycling accident, but that was the catalyst for his death. Not necessarily, it was the root cause that led to his death. It was not necessarily the specific cause of his death. But most recently, for those of us who have been following you on social media, we know your attachment to your late mother and your dedication to her. She passed away very recently, and I've just learned that it was her decision to donate her entire body to science. And you dedicated your career to public health. Public health is complex. I want to just start off with a little perspective that, on one hand, the United States has one of the most advanced health systems in the world in terms of innovation, in terms of the potential of access to care, depending on whether you have good insurance or not. Our investment in medical school preparation, our investment in research, both basic and applied, all that makes the U.S. system extraordinary. And yet we have one of the most maze-like health systems in the world. It's complex. It's such a beast that we can't even figure out in many cases who's making the decision. I remember when your son died, you used the hashtag NMP, not my patient. Why don't you take it from there and tell us what unfolded?
Great. Happy to. Yeah, bittersweet, Gil, but thanks for the opportunity. Let me just, before I get into it, let me just briefly give you, the audience, a little bit about me. My background, yes, is in public health, but I spent 3 decades in what I call the belly of the beast, and that is the acute healthcare system. In nonprofit health systems, for-profit health systems, and academic medical centers, senior, mid-level to senior management positions across all 3 of those theaters, you might say. And the one that is most germane to what I'll relate is the fact that I was a senior VP at an academic medical center here in Southern California, and I became very, very familiar with workflows, the clunky nature of governance, how the faculty interact with students, the whole clinical machine, if you will, and how it intersects with the teaching and research mission of an academic medical center. So, yeah, my son was riding his bicycle home at 1 a.m. He veered to his left around a corner. He collided with a pedestrian. There was no injury to the pedestrian. No claim was filed against him. But he hit his head, and he on the curb, unfortunately, and he had a epidural hematoma, and he lost consciousness temporarily. one of the bystanders called EMS. They scooped him up, took him to a level 1 trauma center, which means the best of the best in terms of trauma care. And he interacted with staff. He was energetic. He was evaluated, then triaged into the surgical intensive care unit. And that's when I got a call that he was in the ICU. And like you mentioned, the next morning I was at bedside with him. I met with the surgical ICU director, faculty member, and he kind of told me what the status was. He had what was called a Glasgow, which is a coma score of 13, which is in the mild brain injury category. It ranges from 1 to, I believe, 15. 13 is considered mild head trauma. So I was told that, this is what's going on. We expect a 6 to 7 day length of stay. And thereafter, he may require some therapy, possibly speech, whatever. Remain to be seen what residual effect he might have from the brain trauma. And on day 3, his condition had improved to the point where he was transferred to an intermediate level of care, telemetry monitored, but a step-down unit nonetheless, because his health status was improving. So what I want to say is in the academic environment, it's a little more challenging than your typical acute care hospital setting, in as much as you have what's called a tripartite mission in an academic center, and that is a combination of teaching, research, and patient care. And it's arguable which of those 3 prongs is put forward as the priority, but it became complicated. And this is a facility that was staffed primarily by floor nursing, physician assistants, and interns and residents. The faculty physicians were typically not very active in his care, and it was a source of my difficulty. But what we know about medical error and the cause of death from several studies, most popular is Johns Hopkins studies. It estimates that it is the 3rd leading cause of death in the United States. And it's perhaps understated because there's no standard definition of what constitutes a medical error. But there are lots of things that combine, whether it is just workflow, coordination, the integration of per diem or registry nursing, the lack of continuity from a holistic patient 360 perspective, the fact that there are electronic health records that oftentimes the clinical team does not really review in depth.
I want to ask you a quick question, Gregg. Anthony's care, you have doctors, you mentioned doctors, physician assistants, nurses. How consistent was the staff on the floor with Anthony's care? Because my experience of academic medical centers and staffing is, often nurses, for instance, who are really the front line of observation of the patient, they're kind of moved every 2 days, like 2 days on, 2 days off, or, and I've even seen cases where, I'm not going to be on this floor tomorrow. Today I'm in critical care. Tomorrow I'm in cardiac rehab. Did you experience that? Was there a consistency of staff? Because it's not just, I don't know the medical records. It's, to some extent, I don't even know the patient. I'm coming on board. I've been off for 2 days. John, who was your son's nurse, is now off, and they don't have time to read the records, and they see your son in sort of a trauma care situation, and if he's doing well, that's great. If he's not doing well, that's what they assume they inherited from yesterday and the day before. I mean, how aware are they in the changing of the patient, your son's status?
Well, that's a big challenge. Workflow, continuity of staff. You've got 3 shift changes in any 24-hour period. Sometimes you've got 2, 12 and 12. But it's it's a challenge to create continuity from handoff to handoff. And in this environment, which is, it's the best of times, the worst of times. The best of times is you have supremely talented people, smart, intelligent clinicians. And the worst of times is that it's a subspecialty, overly hierarchical culture and workflow environment. So with the coming and going, the change in staffing, for instance, that ICU medical director the next day went on vacation for 2 weeks, and then I was handed off I couldn't quite tell who was in charge of my son. And this leads into this phenomenon, which I believe lends to medical error and why it is likely the third leading cause of death in the United States, avoidable death. Is you have this phenomenon because of this subspecialty focus of, well, if it's not my service, it's not within my competence, it's therefore not my patient. And if it's not my patient, it's not my problem. Okay, now that can sound very cold and blunt, but ultimately that's where it goes. And it roots in the sense of implicit bias, a process a clinician goes through. And the first is eyes on the patient. Then it's like, well, what's happening here? Is this within my sphere of capability? And if not, maybe I shouldn't speak up because I don't want to look bad in front of my attending if he or she happens to be in the room at bedside. Or worse, I just don't want to do something that is not in the patient's best interest. After all, I'm a student. I'm a PA. I can't operate without an attending. As a student, I want my senior. I couldn't tell who was in the room and whether they were PG1, PG4, 5, where they were in the pecking order, but no one seemed to have clinical expertise to recognize the apparent distress, respiratory distress that Anthony developed and did not get, in my judgment, proper attention and was the cause of his injury.
Yeah, I think because medicine is hierarchical, particularly in sort of like ER trauma care settings. When you've got a chain of command or command control going on, and something is not going right, it strikes me as it's all dependent upon reaching that person, whether they're in the hospital or they're out at the club about to play tennis. You've got to reach somebody. What happens really with what I'll call someone taking responsibility and sort of suggesting we need to get this patient down to a CT scan and see what is happening here. We need new information. Something has shifted. Was there any sense of, well, 2 days ago this patient had clear cognitive ability, and today they seem confused or sleepy or different? I mean, how does the staff at least physically observe that, short of your saying, my son is not operating at the same level he was 2 days ago? I mean, who steps in and says, look, the patient's caregiver is saying that something is wrong, and they're saying this. What's the game plan? I often find that staff want to be reassuring, and they don't want to be alarmists, but caregivers are not dumb. And I often find you talk about the third cause of death, which is error. I'm wondering if the first cause of death is not listening to the patient, not listening to the caregiver, and assuming what. And I've had doctors say this: who are you going to believe, me or a patient advocate? And in many cases, I have found, in more cases than not, I have found believe the patient advocate, who's gone through this journey before. They're speaking from firsthand experience, doctor. You're speaking from textbook experience. And these days, when you talk about the specialization of medicine, doctors don't know medicine. They know, they know the upper GI, right? I only specialize in upper GI. I only specialize in frontal lobe injury. You got to speak to someone who does, spinal cord injury or cervical injury. I mean, we're getting to that level where doctors are really not doctors any longer. It's like, I only do bathroom faucets. You want someone who does kitchen faucets, go speak to a kitchen faucet guy or gal, person. So I just wanted to get your observation here, because I think we're really getting to is the fragmentation of the health ecosystem, and who's responsible for what, who knows what, and who's intervening or advocating for what is so fragmented at this point that it's not surprising. It's horrific, but it's not surprising that people who could be helped and potentially healed fall through the cracks. So I just like to get your observation as the caregiver who is vigilant. Do you think the system is so broken, fragmented, that patients are just slipping through our fingers?
So much there to unpack, Gil, but I'll say absolutely. The whole listening piece is huge. And as you know, I think there have been studies that a physician listens for 9 to 15 seconds before he or she interrupts the patient and overlays, what in some cases can be driven by implicit bias in a setting where there's accountability and time management, productivity, pressure to move along, keep things moving. So there may be a tendency to want to shortcut the narrative that's coming from the patient, and therefore lacking that kind of narrative input. Certainly the clinician may not be operating on otherwise full information to make an assessment or a judgment about what's going on. But we know our system is complex. You've often mentioned the fact that it's its own client. The system is the customer versus the patient, which is ostensibly the target primary audience for the clinicians. But we've got financial issues, we've got implicit bias, we've got workflow challenges, we've got coordination issues, handoff between staff. I can tell you where it all comes home to roost for me, especially in an academic setting. Again, the best of times, the worst of times, is when there's a call from floor nursing that's urgent, that there's a health status change in a patient, and there's a call reaching out to the attending on call, who then chooses to not respond, and in turn sends an intern or a resident in their stead, and perhaps not in a timely fashion. These things can all stack up. So I almost don't know where to start. You've got workflow issues. You've got book of business driven medicine, where commercially insured patients are seeing
fee for service system. I can't make money unless the system will authorize this CT scan. So if I do it, we're not going to get paid for it.
Just dropping in, you're right on time for Health Unabashed on Healthcare Now Radio. Stay tuned for the rest of the story.
Because there's no how do I justify? I sort of said to myself recently, we don't have a healthcare system in America. We have a sick care system. I mean, why? How does a doctor make money by not doing anything? I mean, think about it. Like, how does a doctor sort of say, well, rather than do this operation or this scan, or sort of like have you come in and look at your cholesterol, I'm going to really encourage you to see a nutritionist so you lose the weight. You don't need eventually the knee operation. Your A1C goes down, your hypertension, blood pressure goes down, your cholesterol improves. I mean, is there money in that? I'm not so sure that doctors are getting reimbursed for that level. I mean, they make the real money when you need the hip replacement, so to speak, or you need the stent. They don't make the big money by keeping you out of that situation. So I don't really know the economics of the trauma care, but from what I understand in your son's situation, it was a question of who's in charge of your son. I mean, who's taking command of his getting out of the hospital healthfully? I mean, you have a young person who arrives and they say mild, probably going to be here 6 days a week and out, and then and doesn't make it. What happens between the probably will be out in 6 days, is joking around from their hospital bed. And as I understood it, then please correct me if I'm wrong, Anthony's cognition was improving, and then deteriorated. Is that correct?
Yes, that is correct. His condition was improving while he was transferred to a step-down unit.
And then it declined, and there was no, like, holy, you know what? This kid's cognitive ability is not getting better; it's getting worse. Let's move him to a more intense, oversight, and let's get a scan going on here. It's like swing by the bed and look at the charts and look at the box, the instruments, and sort of like, how you doing, Mr. Masters? And out they go.
Yeah. Again, back to the complexity of the ecosystem. We've over-engineered this to the point that we need navigators, we need advocates. There should be signs: enter at your own risk of a hospital setting.
That's horrific.
If you really don't know how, it's
for someone who knows the system as well as you do. Also, you trust the system. And then
yes.
I think there's a lot to. We're never going to unpack the whole journey, but what you and I have talked about on this program for many of our guests, and now you're in the guest seat, and I thank you for that, is we have a fragmented health ecosystem. It's splintered. It's like, not my patient. Well, it's like, who's in charge? Who is in charge of this? I know we have a hospital president. I know we have a chief physician officer. I know we have a chair of the Department of ER, Department of Cardiology, but actually, who's grandly in charge of the outcome to the best of the system's ability? I don't think we have a chief outcomes officer that oversees departments. I think we have a lot of functionaries in medicine who are trying to move the dial day by day. I think your son's story, Anthony's story, is a critical story for those of us in the health system to share, who care and are in this. We know many people have been on the show who are passionate about being healers and physicians and are trying to make it better. I think that your life case study is a case study that should be studied in medical schools, and for people who oversee quality control and actually risk management in hospital systems. Sadly, it is like the perfect storm. And I don't know if you feel that way or not, but I think it's the perfect storm.
You mentioned some of the guests we've had on this program, two in particular, Ilana Yurkovic, who wrote the book Fragmented Medicine, and then our colleague Gita Nair, who wrote the book Dead Wrong, talking about some of the integration problems of data sets informing patient care choices. I mean, it's what we have is a healthcare system that is way too complex for people to understand, let alone navigate and access in a prudent way. We need support and resources to make that happen. But bottom line, in these environments where you have super talented people, and make no mistake, I think Yurkovic said, there are no bad actors here. There are only victims. The docs are burnt out.
Including the doctors.
Yeah, actually, the docs are burnt out. The nurses are burnt out. The staff turnover. It's incredible. And, everyone is trying their best. These are heart-centered, mission-driven people who are put in a system that is just almost impossible to make work correctly 100% of the time. And when you have these kinds of opportunities for gaps, if someone isn't leading, back in the day before hospitalists, when admitting physicians were primary care doctors, including internists, GP surgeons, and so on and so forth, and not deferring to an inpatient hospitalist to basically be a 360 eyes on the patient kind of caregiver, you had attendings who would do that. But now it's deferred to hospitalists, and in academic centers, you have a hierarchy of faculty and then the teaching core, residents, PAs, interns, okay? So if someone doesn't lead in the context of team-based care, then the quality of the patient's experience most definitely suffers. And I think there's quite a bit of studies that have gone on that have documented the value, the upside of team-based care, but also the opportunities for failure. And there are opportunities for failure. So we got to simplify this process.
You got it, brother. And I just want to say, on the opposite end of your family's journey, your mother just passed. She lived many years, well loved and cared for. You were there all the time, and I know that she was you were very close to her. She was very close to you, and she donated her body to science. And you mentioned that you thought that in the ceremony where the system accepts a person who's donated their body to improve medicine, you thought of, maybe 20, 30 people would show up to the ceremony. And you mentioned there were like 1,000 people there. I think that what you've just said, Gregg, is so true. At the heart of the system, from the people who imagine themselves being healers and are studying in a medical school, to those that are there, inherently, they want to be great nurses, physician's assistants, nurse practitioners, pharmacists, physicians, floor staff. They want to be great. What happens? Maybe the system doesn't sort of suppresses their imagination and passion to be as great as they might be. It's not them. It's it. And I think that you're continuing to tell Anthony's story, your mother's story, your reaction, your journey is part of getting us all to unite around you and what you feel is important, Gregg, and making us realize we cannot tolerate the patient being the victim. That's the journey we must all embrace. And again, I want to thank you for co-hosting this program and making it so popular. I appreciate your being a guest to talk about this, and also I'm saddened that you're a guest having to talk about this. But I thank you so much for everything you do and the courage you had of joining me today to explore Anthony's life and his journey, and your mother's wonderful journey of life and your love for both of them. Thank you, Gregg.
Thanks, Gil, and a big shout out to UCSD School of Medicine and their body donation program. It was just an amazing experience, and I'm just blown away by the talent of these amazing students, whether they're medical students or in School of Pharmacy. Their commitment to the profession is impressive, and I just love the fact we're in good hands. We just need to simplify the system.
Amen. Thank you all.
Thank you, Gil.
And that, dear listeners, is the last note for today's melody. A huge thank you to our worldwide audience for tuning in. Stay social with Gil and me on Twitter by Gil_Bashe, and that's BASHE. And Gregg Masters, MPH, and that's Gregg with 2 G's. And don't forget to give your tweets some zing with our hashtag HealthUnaBAShed. Until we meet again, pursue your passion for better health and with no apologies.